Welcome to today's webinar for a discussion on primary prevention of stroke. My name is Jeannie Luciano, and I'm the Senior Manager for the Stroke Program with the American Heart Association. Before we get started, I'd like to go over a few items so you know how to participate in today's event. The webinar is being recorded and will be sent via email within 24 hours. Just so you know, from a disclaimer, the recommendations and opinions are not reflective of the American Heart Association. So before we get started, recording is in progress. The slide deck will be available in the handout section during the presentation and sent out with the recording after the webinar. A link to the recording will be emailed following today's presentation. If you're experiencing any technical difficulties, try refreshing your browser, logging out and back in. If these steps don't correct your problem, please contact the GoToWebinar customer service team. It will be on your confirmation email. We will have a question and answer session following the presentations. Questions can be entered at any time, and we will review them at the end. Closed captions are available by clicking the icon at the bottom of your screen under closed captioning. So we are kicking off, you can keep going there, Tatiana, thank you. So we are kicking off Stroke Month 2025 with a wonderful and informative talk by a quite impressive panel. I'm going to introduce our panel and then we'll have the presentation. Dr. Nishant Shah is currently a faculty member at Duke University Medical Center, Division of Cardiology, and the Duke Clinical Research Institute. He is an expert in preventive cardiology, as well as a member of the Cardiometabolic Prevention Program. Dr. Shah's research revolves around the clinical manifestations of genetic lipid biomarkers, particularly lipoprotein A and advanced dyslipidemia. He is also interested in implementation science at both the primary and secondary prevention level. He also serves as co-chair of working groups across several national societies, including the American College of Cardiology and the American Society of Preventative Cardiology. Dr. Shah is very passionate about clinical education and has won many distinctions in education throughout his training. Our next presenter will be Dr. Michael Mullen. Dr. Michael Mullen is an associate professor of neurology at the Lewis Katz School of Medicine at Temple University. He is a board-certified vascular neurologist and directs the Comprehensive Stroke Center at Temple University Hospital. Dr. Mullen's research interests include acute management and secondary prevention of stroke. Dr. Mullen is a valued member of the American Heart Association's Stroke Systems of Care Advisory Committee. He is passionate about optimizing stroke care in his community and beyond. Our next speaker is Dr. William B.J. Hicks. Dr. Hicks serves as the president of the medical staff and as co-director of the Comprehensive Stroke Program at Ohio Health Riverside Methodist Hospital. He is also the medical director of the Mobile Stroke Treatment Unit through Ohio Health and a vascular neurologist for Ohio Health Neurological Physicians. Dr. Hicks was named the 2023 Equity Hero by the American Stroke Association, and hot off the press, he will be honored this June as the American Heart Association 2025 Physician of the Year. So I'm going to hand off to Dr. Shah. Dr. Shah, the floor is yours.
Awesome. Well, thank you everybody for joining us, and I feel very fortunate to be joined by an outstanding panel in Dr. Mullen and Dr. Hicks. So what my goal is to sort of give you a view in through my eyes in the world of preventive cardiology and what we sort of see in our clinic on a regular basis, and hopefully what we can gauge out of all of our presentations that there's more than what meets the eye in primary prevention. And so I'll start with the case, a case that we routinely see in clinical practice. So a 55-year-old female with hypertension, hyperlipidemia, obesity with a BMI of 35, type 2 diabetes, last hemoglobin A1C of 7, who presents for a cardiovascular risk evaluation. She has a strong family history. Father had an MI at 45, mother with a stroke at age 55. This, for me, it meets the definition of premature atherosclerotic cardiovascular disease. So she doesn't smoke, doesn't drink or use any illicits, works a quite sedentary job, doesn't routinely exercise, and her only medications are lisinopril 5 milligrams for hypertension, atorvastatin 80 milligrams, and metformin 1,000 milligrams twice a day. I'd like to just take a pause here and love to get my co-panelist thoughts, Dr. Mullen, Dr. Hicks, on just their initial impression of a patient like this, who I imagine they may be seeing a lot of as well.
Yeah, thanks. I love that you included family history. It's funny. This is like my with residents and med students, they often forget, right? It's such a huge predictor though, right? And clearly there is a red flag in addition to the patient's own individual risk factors, right? So I think that there's clearly a lot of opportunity there, but that family history definitely, always makes me worry. And I think you can use that in talking to patients because it resonates with them when you're able to say, look, this disease runs in your family and we need to be aggressive about it.
Yeah, I think that's perfectly described and discussed. The other thing I would add is that oftentimes in this country, we will see things that seem to be a little bit on the mild spectrum, so to speak. So people feel this false sense of security. I'm taking my medications. What's the big deal? But there's still more work to be done. And I think far too often, even for those that are getting routine care, there's still some tweaking that needs to be done, because the more and more we learn about cerebral vascular disease or vascular disease writ large, good is sometimes not good enough. We've got to strive for great. We have to continue to get those numbers into excellent shape, especially with the family history you alluded to.
No, I think that's spot on, and I completely agree. And so just a little bit about primary prevention, at least through the eyes of a preventive cardiologist. We have through the AHA and the American College of Cardiology, a risk calculator, if you will, that really puts people into 4 different buckets of risk. And what we're trying to identify is what someone's 10-year risk of an atherosclerotic event is going to be. And so those buckets are low risk, borderline, intermediate, and high. Low risk being less than 5% chance of an event in 10 years, borderline to intermediate, somewhere in between, and high, about a 20% or more chance of an event in 10 years or so. And based on that, we can decide on what our management strategy is. However, it's really important to note that when you put somebody into this risk calculator to understand their 10-year risk, it assumes that the patient has not had a prior CV event. That makes sense here because we're talking about primary prevention. It also assumes that the patient is not diabetic or has an extremely elevated LDL, like an LDL greater than 190, and are between the ages of 45 and 75. So if you think about our patient is type 2 diabetic. So this risk calculator doesn't even impact them. It's not even relevant to them. They already have high risk and we need to strive for aggressive medical optimization, just like Dr. Hicks and Dr. Mullins were saying. We have to strive for greatness. We can't just be okay with good enough. So I also like to throw out there that there are a lot of things that these risk calculators in general don't keep in mind. And that's a combination of personal characteristics, comorbidities, and biomarkers. So when we talked about this patient's family history, that's not in the risk calculator at all, but she has a premature family history of ASCVD. There's other conditions that you can see here, like CKD, inflammatory conditions. I tell my fellows all the time, make sure you get, in women in particular, a gestational history. Did they have preeclampsia or not? That also increases their risk of heart events, as well as other vascular events. Premature menopause as well. That can also increase risk. And then, of course, biomarkers. We have a lot of biomarkers that allow us to be more precise in our risk assessment, like CRP levels, Lp(a) levels, and so forth. So those are very important. The point here is that the traditional risk factors like of diabetes, hypertension, hyperlipidemia, those are just the tip of the iceberg. There's so much more than what meets the eye. And so with our case continued, this is her blood pressure in clinic, 142/82. You recheck it, still elevated at 139/85. Her LDL on atorvastatin, very important to know, LDL on atorvastatin, 80 milligrams, highest intensity, 110 milligrams per deciliter. Before atorvastatin, her LDL was 200 milligrams per deciliter. Her thyroid was fine, hemoglobin A1C elevated at 7.3. We got a lipoprotein A, which was elevated at 200 nanomoles per liter, and her hsCRP is elevated at 2. Any other thoughts, Dr. Mullen, Dr. Hicks, based on these sort of the vitals and cardiometabolic profiles?
Yeah, I mean, there's a lot there, I guess, right? So her blood pressure is kind of very borderline. She has not gotten a 50% reduction in her LDL, right? Which is you get, we like less than 70 in the stroke world, but at least a 50% reduction would be good, right? That A1C is moving in the wrong direction. Lipoprotein little a, don't love that. That's its own problem, right? But there's a lot of things there that are not where we want them, I think.
Yeah, and I think those labs connect back to that family history. And I think we're starting to understand why there's premature vascular disease with this family. And that really serves as a clue. We're doing, we're being aggressive with the statin therapy. And yet here we are with the LDL. And again, the lipoprotein A really has us thinking about the genetics side of this proverbial street.
Absolutely, completely agree. There's more here than what comes off on first glance. Go ahead, Dr. Mullen. Sorry.
No, I was just going to say to BJ's point earlier too about, we see patients like this all the time who they're going to their docs, they're seeing people, right? They're taking their meds, and kind of everyone's like, oh, you're doing fine, right? But actually, like, they're above goal for their, right? Like for numerous risk factors, and so there is a therapeutic inertia, I think, that's both like a patient and provider side that you kind of have to fight against.
Absolutely, absolutely. So we went ahead and did one step further and got another sort of precise type of biomarker analysis, a coronary artery calcium score, and that is also elevated as well. So, many of us in prevention circles, refer to this as subclinical atherosclerotic disease. She didn't have an event yet, so we're not calling it clinical, but we already have evidence of atherosclerosis just based on the calcium score alone. So this person is at very high risk. And so how do we modify this risk? What can we do? So there's a whole myriad of things that we can do. And I apologize, let me just go back a slide here. So it all starts with the foundation of lifestyle modifications, okay? Now there's we're gonna need to do more than lifestyle modifications alone for this patient, but it's important to know that all of our patients need to have heart healthy lifestyle or brain healthy lifestyle modifications, if you will. So in general, we want to make sure patients have a structured program of self-monitoring of food intake, physical activity, and weight. Whether that is through something like through a trainer or through an actual program, dedicated, formalized program, or a way they're doing it on their own, but they need to have some way of monitoring. We recommend at least 150 minutes a week of moderate intensity activity or 75 minutes per week of vigorous activity for exercise. Followed by an additional, if you're really trying to lose weight, you're trying to bump that up for 200 to 300 minutes a week to avoid regain, after a year. So if you're trying to maintain 150 minutes of moderate or 75 minutes of vigorous, and then if you're really trying to lose weight, you need to push that a little bit higher. We also like to recommend, a very balanced caloric intake. So making sure that the energy expended is always more than the energy consumed. So keeping in mind of lower calories, lower carb type of meals. We have evidence that Mediterranean-based diets actually have improved cardiovascular outcomes, decreased all-cause mortality as well. And I think it's important to remember that even a 5% total body weight loss is associated with so many cardiometabolic improvements, blood pressure, LDL, triglycerides, glucose levels. You may not see that where you may not be where you want to be in the mirror, let's say, overall, but internally, it makes a significant difference in your cardiovascular risk. So there's wins at every level of weight loss and good lifestyle. But this patient has diabetes, and we've seen an explosion of data on SGLT2 inhibitors and GLP-1 receptor agonists and how they can improve someone's vascular risk. So we don't need to go through that for the sake of time, all the individual trials, but I make this slide to show you guys that there is a ton of evidence that SGLT2 inhibitors and glucagon-like peptide-1 receptor agonists can be very beneficial in modifying vascular risk across the globe. So patients with diabetes or without diabetes. In this particular patient's case, she most certainly would benefit with these agents as she is diabetic and she is obese. And so when we talk about obesity, the GLP-1 receptor agonists have really kind of changed the paradigm in how we think about managing obesity, especially in patients with type 2 diabetes or who are at high vascular risk. This is just an example from the STEP 1 trial that looked at semaglutide at 2.4 milligrams once weekly compared to placebo. And you can see the almost 15% reduction mean reduction in body weight. This is also similar to tirzepatide, which is a GIP and GLP-1 receptor agonist combo, which also showed at various dose-dependent response to weight loss, and even at the lowest possible dose. I know difficult to compare across trials, but very similar to what we saw in STEP 1, about a 15% change in mean body weight. Hypertension, this patient is hypertensive. We checked it twice in clinic and confirmed that. And our guidelines currently recommend blood pressure less than 130/80. And then depending on someone's 10-year ASCVD risk, if it's above 130/80, may advocate for early pharmacologic therapy combined with those lifestyle modifications. But also important to remember that blood pressure may be very different in clinic than it is at home. And so keep in mind that you want to have an idea both in the clinic and outside the clinic what blood pressure looks like, as it can fluctuate over a 24-hour period, as I kind of showed down here. And so in general, we want the blood pressure to be under 130/80 consistently on average. Now, in terms of how to manage someone's lipids, it's really based on their underlying risk, and that is the bottom line. So in the primary prevention setting, right, you have to understand what is the risk within primary prevention. Do they have that what we call high risk primary prevention, where they have subclinical atherosclerosis but just haven't had an event yet? Or are they pure primary prevention where there's no evidence of atherosclerosis but they're just at risk? If they have subclinical atherosclerosis, or they have what we call ASCVD risk equivalents, diabetes, familial hypercholesterolemia, and so forth, we actually aim for an LDL under 70, even in those patients have not had a clinical event yet, okay? But if they're purely primary prevention, there's no other reason to suggest they have atherosclerotic disease or have a risk equivalent of atherosclerotic disease, then going under 100 is very reasonable as long as you're monitoring them closely in terms of your LDL goal. And so in terms of how to do that, you want to start with the maximum tolerated statin dose and adding an adjunct therapy such as ezetimibe if necessary to drive them to your individual LDL goal. If that fails, or they have statin intolerance, or you can't get to goal despite max dose statin or adding Zetia, or Zetia is not going to really help you because they still have an LDL that needs to come down, that's when we start thinking about the PCSK9 inhibitors or the ACL inhibitors like bempedoic acid or bempedoic acid combo with ezetimibe, or ANGPTL3 inhibitors, which especially are emerging as more other therapies in addition to PCSK9 inhibitors to really lower LDL. So a lot of options here to think about. Okay, let's do the next slide here. There we go. Now, the other thing I just want to touch base on a little bit, because we're going to hear more and more about this as drugs are currently in clinical trials to target this molecule. It's called lipoprotein A. Lipoprotein A is a very genetically based biomarker, lipid molecule, because it can either be inherited or it can be created out of your own genes de novo. So it's very genetic. Lifestyle modifications do very little to lipoprotein A. There's a lot of particles of lipoprotein of various sizes. It's very atherogenic. It has an LDL core. Standard assays don't necessarily distinguish between the LDL that's on lipoprotein A versus LDL that's freely circulating. So your LDL, if you have a patient with an LDL that's very difficult to control, it might be because they also have high Lp(a). And they have inflammatory, thrombotic, and atherogenic mechanisms of cardiovascular disease. So very important to know, it is elevated, at least in all comers, 20% in men and 20% in women. And in patients who have familial hypercholesterolemia or patients with an LDL, let's say greater than 190 with a very strong family history, like our patient, it could be even higher. And in our patient, she had an LPA of 200 nanomoles per liter, which is considered very high. So we do actually have LPA in our current guidelines. In the 2018 ACC/AHA guidelines, they recommend screening for LPA at least in intermediate or borderline risk patients with an idea that 50 milligrams per deciliter or higher is considered a risk-enhancing factor. But our European colleagues recommend screening once in a lifetime. And more and more, as more and more evidence is emerging, that is sort of the direction that I believe our guidelines are going to move towards as well, especially as we have therapies that target this molecule, assuming that the outcomes of lowering LPA are positive. So what can you do today for patients with Lp(a)? So, many of us in prevention circles, if we have a patient with elevated Lpa, we lower their LDL as low as possible because they have that what we call ASCVD risk equivalent. And so we drop their LDL to under 70 if we can. We consider aspirin therapy if the bleeding risk is low. We try to modify what we can modify: obesity, diabetes, hypertension, lifestyle. We want to cascade screen all their first degree relatives. Make sure what that means is check every first degree relative for Lp(a), and then consider opportunities for clinical trials if there are any locally for Lpa lowering therapeutics. And so our case continued. Given the LDL was still high despite atorvastatin 80, ezetimibe was added as well as a PCSK9 inhibitor with a repeat LDL after 3 months at 50 milligrams per deciliter. All of her family members were screened not only with the lipid panel, given the genetic basis of her LDL, but also for a lipoprotein A. For blood pressure, lisinopril was increased to 20 milligrams at goal blood pressures. She was started on a GLP-1 receptor agonist at a 35-pound weight loss and was able to actually come off metformin, and started living a more active lifestyle and trying to do at least 150 minutes per week of moderate activity to maintain an optimal cardiovascular profile. So I'll go ahead and stop there and see if my co-panelists have any additional thoughts.
I have a lipoprotein(a) question. If for patients who are at high risk of vascular events, if they have lipoprotein(a) that remains quite elevated, despite LDL control and max tolerated statin, do you change them to PCSK9 inhibitors?
That's a great question. So if their LDL is elevated despite being on a max tolerated statin, then I do. Currently, PCSK9 inhibitors aren't indicated just for elevated Lpa alone, and so oftentimes many of my patients will be on both max tolerated statin and a PCSK9 inhibitor. PCSK9 inhibitors do drop Lpa by 20 to 30%, and there's been some post hoc analyses from large PCSK9 trials showing that maybe there's a benefit there. Again, observational, not pre-specified analyses, but that being said, the goal being to lower the LDL as low as I can. And so if a PCSK9 inhibitor helps me, absolutely.
For the purpose of the discussion, and I hate to steal the thunder from others who might ask a certain question, but Dr. Shah, phenomenal discussion and in a manner that really makes this these marching orders for patients digestible, for lack of a better term. Maybe I should say pun intended. But how do you, what's your way of counseling around the moderate intensity exercise and maintaining an active lifestyle when oftentimes patients that have these elevated vascular risk factors, and in this patient, this vignette might be an exception because of the family history component, but how do you reach your patients when it comes to that discussion?
Yeah, no, it's a great question, and I feel like the conversation always changes patient per patient. Once you understand what their life is like and kind of walk in their shoes a little bit. And you're right, it's tough in that there's not like a standard template. What I try to look at first and foremost is how much the patient is doing. Oftentimes by the time they come to see me, and so I might have a little bit of a biased approach because they've already kind of gone through the rundown with maybe their primary care physician or maybe even another cardiologist or a neurologist even. But sometimes these patients are already doing everything. And it's really just optimizing their genetic risk, things that they can't control. And so, what I tell them is like, look, you're doing your part. Let me do mine. You know what I mean? And try to optimize them that way. Other people who want a little bit more direction on what to do, I kind of break down to see, okay, well, what are you doing now, and how can we modify that? And I try to come up with, I don't want to say an exercise prescription, like formally per se, but I kind of come up with a plan on how we can make it work for your life. And so, it depends on the level of understanding of the patient. But what I try to generally tell someone who may have the most basic understanding is whatever exercise that you're doing, you shouldn't be able to make a complete sentence while doing it, just to make broad strokes understanding of like the level of intensity they should be working at. I always recommend a combination of resistance training with aerobic type of training, so that we also focus on building lean muscle, maintaining lean muscle. So resistance suggests more like weights or legit machines to weight machines, if you will. To really make sure that they boost their metabolism in different ways. One of the easiest thing is just going on brisk walks. That's what we in the guidelines, they define kind of moderate intensity activity, brisk walk being one of them. And I just kind of go from there and see, how they can do that. Another challenge we have is sort of for very busy working folks, how do they, they have to take care of kids, they may not have access to a gym, things like that. How can we modify their day to incorporate exercise? And so oftentimes I tell a lot of my folks who take calls, like all of us do sometimes, is if you don't have to be on camera, why don't you take the call on a walk? You know what I mean? And just kind of think of creative ways. Think about standing desks, treadmill desks. Think of creative ways where you sort of build in dedicated time for exercise in your workday. So you sort of prioritize it rather than just doing it when it's convenient.
I guess I'll ask another question, since I don't see any questions in the chat or in the webinar. Weight loss you mentioned, and I love that you have 5% or more, right? I think that's a key point in my practice. Explain to patients they don't need to lose 50 pounds, right? That small amounts of weight loss are meaningful. But and diet and exercise, I'm always talking about the Mediterranean diet to people. But I'm wondering, do you have resources, or it's hard to get people in to see nutritionists? Obviously HA has, right, we're on HA call, HA has great resources that you can send people to, but wondering in this world of like apps and online and everything, if there's, kind of like specific things that you like to recommend for people to help them for like nutrition, counseling, dietary change.
Yeah, no, it's a great question. And nowadays we live in a world where, man, people are just exposed to all types of information on social media, on the internet, on TV, kind of everywhere. And some is right, some is wrong, and it's tough. I always refer to kind of as credible of a resources as I can provide. So the AHA and ACC are great. We pretty much use a lot of AHA, ACC resources embedded in our EHRs, and so I always provide handouts that through our electronic medical record to patients. We have nutritionists that we work closely with, but I understand not all health systems may have that, and so having those sort of standardized handouts like that the AHA provides online will be good. There's a lot of like obesity societies as well that have like patient-facing materials that I refer people to oftentimes. And there's not like any one particular program that I necessarily endorse or recommend, obviously for conflict of interest reasons. So I try not to, necessarily recommend one brand or one group compared to others, but I kind of encourage and empower the patient to look on their own to see if there's like resources in their local communities that really seem to fit with what they're trying to do.
I have a quick question in the question panel, and we have questions that are coming in that our panelists can't see. But just because we'll go over them at the end, but just because I think this one falls in well right here. What is the recommendation for familial dyslipidemia? For instance, someone who has had lipid elevation since childhood.
Yeah, great question. So in my world in cardiology, if they're in primary prevention and they don't have an elevated LPA and there's truly no evidence of subclinical atherosclerosis, we definitely want the LDL to be treated because these are genetic things. So under 100 at least, LDL or a 50% reduction from baseline, whichever is lower. If they did have elevated LPA or they do have subclinical atherosclerotic disease, then under 70 comfortably. And some people would argue to even drop it under 55, but at least our guidelines suggest keeping it under 70 at the minimum.
Perfect, thank you. I think we can move on to Dr. Mullen's case here.
All right, great. So happy to talk. We can go to next slide probably. I'll mention that I do receive royalties for articles on broad stenosis. Next slide. Okay, so the case is a 68-year-old woman with a known right cervical internal carotid artery stenosis. Fortunately, I put animations in, so you can just click through them to get the bullet points. So this was diagnosed 5 years ago. It's been getting watched annually with carotid ultrasound. It's progressed from moderate stenosis to now severe stenosis by ultrasound criteria. Patient gets a CT angiogram, which confirms 85% stenosis on the right, 40% stenosis on the left. So then the patient is referred for an evaluation. Next slide. This is the patient's past medical history: hypertension, diabetes, hyperlipidemia. Forward. Their social history: they drink 1 to 2 drinks per night. They're an active smoker. Forward. These are their medications: aspirin, amlodipine, metformin, and atorvastatin. And here's some of their recent data. I won't be there. So then, yes, you can see blood pressure a little high, A1C a little high, LDL a little high. Next slide. So now what? So the patient, typically in this scenario, the patient will be completely convinced that they're going to that they have about 100% chance of having a stroke in the next 24 hours, and their primary questions will be, who's going to fix my carotid? When will they fix my carotid? How will they fix my carotid artery? And so those are the patient's questions. And so the trick here is kind of going through backing that up a little bit and saying, should we fix their carotid artery? And what else can we do on the medical management side? Next slide. So when we think about carotid artery disease that's asymptomatic, if you look at the classic trials that looked at carotid revascularization compared to medical therapy, they showed that carotid revascularization had about a 3% upfront risk of perioperative stroke or death from surgery. And the result of that was about a 1% absolute risk reduction in stroke per year. And just putting some numbers around that, that meant that the medically treated patients had a 2% per year risk of stroke, and the surgically treated patients had a 1% per year risk of stroke. So even just there, it's already, if you can get, that's surgery's looking a little bit less good based on just on that, right? So you're looking at a 3% upfront risk for a 1% risk reduction per year. The problem with that is that most of the patients in those classic trials were not on things like statins, that medical management was actually very poor at those times, because they're very old trials. Actually, many of these patients were completed their time in the trials before statins were even in routine practice. And we know, next slide, that high dose statins lower risk. And based on that old data, although asymptomatic carotid revascularization became very common in the United States, in other areas, other countries, it was really not adopted. And we know from contemporary case series with modern medical therapy that in patients with asymptomatic carotid stenosis who are on aggressive medical therapy, the event rate is somewhere between 0.5 and 1% per year. Next slide. And so that is actually lower than in the surgically treated patients in those classic trials. So why does that matter? So this picture gives you kind of a rough example of what that endarterectomy data look like. The red is the patients who had an endarterectomy. There's a little bit of an upfront risk, but then over time, they have less strokes than the medically treated patients. And so at around 3 years, you start to break even, and around 5 years, you start to have a benefit. 5 years of life expectancy post-endarterectomy, you start to have a benefit. If the blue line, the slope of that line changes, meaning the event rate in medically treated patients goes down from 2% per year, things start to look very different. You can advance, please. And then one more time. And so as the event rate in medically treated patients gets lower and lower, you get to a place where it's going to take longer and longer for those curves to cross, longer and longer for the patient to have a benefit from endarterectomy. And you could get to a place where you never have a benefit, where you're only accepting increased risk from doing the procedure itself. Next slide. Some people have argued that we're already in that place and that perhaps we should not be doing any carotid revascularization for asymptomatic patients. I'm not entirely sure if I'm convinced of that yet. I think there is a lot that we don't know. There is a big clinical trial called CREST-2, which will be hopefully answering this question. That trial completed enrollment, but we won't have results for probably another 6 months or so, six to 10 months. So for now, I think the key is to help explain to the patient that asymptomatic carotid stenosis is a low-risk condition that the benefit for carotid revascularization is uncertain. We do not know if it is helpful. And then to really try to engage the patient in shared decision-making around that. Next slide. And so my approach to this patient is to explain, you can just click through so that all those, yeah. So my approach is to explain the risks and benefits of revascularization. So I want to emphasize to them that this is not the time bomb that they think it is, that the risk per year of stroke is probably somewhere between 0.5 to 1%. That carotid revascularization has a upfront risk of myocardial infarction, stroke, or death that's somewhere in the 3 to 4% range. And that comes at a benefit, an annual benefit in stroke risk reduction of somewhere between 0 and 1% per year, right? So importantly, when we think about different ways to fix a carotid artery, carotid endarterectomy, transfemoral carotid stenting, and a TCAR, that total rate of MI, stroke, and death is pretty similar across, or seems seemingly similar across the three. It's not really clear that one is superior. A little bit of trade-off. You've got a little bit higher risk of MI with endarterectomy, a little bit higher risk of stroke with the stenting procedures, but there isn't one clearly superior modality there. And so when you put that all in aggregate, the overall benefit of carotid revascularization is uncertain. It is perfectly acceptable to do medical therapy alone. It is also acceptable to do medical therapy plus revascularization, until we have a more definitive clinical trial. And I think if you can convey that to patients, what you'll see is that patients very much self-select. There are some patients who will say, like, doc, I cannot live knowing that stenosis is there. I haven't slept, right? Like, since I've been waiting to see you, like, someone's got to fix this. It has to happen. And you'll have other patients that are equally extreme on the other side who will be like, no way, no how, no one's touching me with the procedure. If I can avoid it, I'm good, right? And so I think it's important, kind of my role here is to try to just help the patient to have an accurate lens of the risks and benefits so that they can make a decision that is concordant with their beliefs and values and interests. The other part of my role, though, is that last bullet: aggressive risk factor management is critical. So I think it's important for patients to recognize that carotid stenosis, the problem is not just that one carotid artery, right? If they have carotid stenosis, they have atherosclerosis throughout their entire body. They are at an elevated risk of myocardial infarction, and other adverse cardiovascular events, and they need aggressive risk factor management to lower the risk, not just of stroke from that carotid, right, but to lower the risk overall. I mean, there's a reason that after endarterectomy, the stroke risk wasn't 0% in those classic trials, right? And that's because these patients have vascular disease throughout their body. They're at risk for stroke from a host of other mechanisms. Next slide. And so, this patient, there's a lot that we could do. So they're just on aspirin. Actually, there's compelling randomized trial data for things like low-dose rivaroxaban can help reduce the risk of vascular events in patients who have carotid artery disease. Their LDL is not at goal, as we just heard. You could add ezetimibe. You could change them to rosuvastatin or PCSK9 inhibitor or some of these other agents. They have moderately elevated triglycerides. That could be a therapeutic target. They have diabetes and are just on metformin. They should be on a GLP-1 or SGLT2. Their blood pressure is not optimal. They're still smoking. They're drinking too much. Pretty much everyone can always do better with the healthy eating and exercise. So there is actually a tremendous amount that you can do non-invasively, right, in terms of medications to reduce the risk, which helps not just that single vessel, right, but helps all of their vessels. And the key thing to recognize that there's nothing you can do medically. There's actually so much you can do medically. If you try and do it all at once, the patient will fire you. So the real question is kind of working with them in a staged manner, oftentimes to sort of escalate care and get these risk factors under control. Next slide. So what happened with this patient? So this patient, during that visit, we transitioned them from atorvastatin 80 to rosuvastatin 40. That's a slight step up, and added rivaroxaban because they did not have anything that suggests they were high risk of bleeding. We talked about reducing tobacco and alcohol use, which the patient was able to do. A lot of my patients struggle to get to 0 cigarettes, it seems, but they'll go from a half a pack or a pack a day to a couple cigarettes a day. And so I'll take it, even though I keep nudging for more. We talked about home blood pressure monitoring to see where their blood pressure was. And The patient actually elected, you can go forward, elected not to proceed with carotid intervention and pursue just medical therapy alone. And at 2 years of follow-up, they were stable, no events with stable velocities on their carotid ultrasound. And here's the just copied in the table from the recent guidelines on asymptomatic carotid artery stenosis, sort of consistent with what we did. The only class 1 recommendation is shared decision making, right? And sort of making sure that you're doing this carefully with patients. And I'll mention that carotid revascularization is a 2B recommendation, and it's something that might be reasonable. It's may be reasonable, being the word of there. I guess I'll stop there for comments.
We do have, we're going to do questions at the end, but there is one that I think is directly related to this. How do you decide on which antiplatelet to use for a mild to moderate carotid stenosis? And there's another question about, do your patients who have carotid revascularization continue on antiplatelet therapy?
Yeah, so in terms of antiplatelet therapy, I actually find the COMPASS trial data, which has been subanalyzed to exclude patients with coronary artery disease, looking at patients who have peripheral artery disease and carotid disease, to be fairly compelling, maybe very compelling. And so for patients who are not at a high risk of bleeding, haven't had prior bleeding, have normal kidney function, normal platelet counts, things like that, I typically like the combination of aspirin and low-dose rivaroxaban. I think that's generally underutilized in practice. For patients who are a higher risk, I will typically just use single antiplatelet therapy, and I think by guidelines you could use you could have your pick. So typically for me, it's aspirin or clopidogrel.
I'm going to throw this question out there too. It says, do you use an upper age cutoff for carotid revascularization surgery?
Well, yeah, so I guess, so one other question. So the second part of that first question is, would I stop the antithrombotic therapy after carotid revascularization? And definitely not, right? Because these patients are at an elevated risk of vascular disease generally. And then upper age limit, you know, these are small, it's a small absolute benefit, right? With a relatively high upfront risk. And so the old AAN guidelines suggested a 5-year life expectancy to consider intervention on a asymptomatic carotid, and I think that is reasonable.
This was
Okay,
great.
Go ahead, Dr. Hicks, I'm sorry.
Yeah, just a great synopsis on a clinical conundrum that we've known about for several decades, yet we still don't always get right. And by the we, I mean us providers, physicians, primary care, subspecialists, cardiologists, neurologists, everyone's complicit, surgeons. And, you know, I love that the vignette was, you know, the patient getting very antsy. Well, we've all experienced clinicians getting very antsy on these scenarios. And it really is due in large part to the unfortunate habit that we developed in this country of saying that, you know, the procedure is the way, the truth, the word, the truth, and the light, before the data is shown itself. And, you know, in the stroke world, cerebral vascular world, we've had various examples of that with other disease states, but still in the same ballpark of atherosclerotic disease, be it carotid occlusion, be it intracranial atherosclerotic disease, where patients were getting intracranial stents without the Sampras trial being finished. And then once it was, then all of a sudden people had to change their tune, and you know, pathways and entire stroke programs felt a disturbance in the force, so to speak. So great setting of the table around the CREST-2 study, which has been enrolling for a long time, but we are all waiting with bated breath on the results there, and we'll have really tangible modern data that we can utilize for this this condition that still remains somewhat controversial with those that don't adhere strongly to the data and the science. All right. Well, we've got, you heard from Dr. Shaw, you heard from Dr. Mullen, two sides of the same coin, as we say, from the preventative cardiology space and the vascular neurology space. Since we are pressed for time, I've got a bit of a tongue-in-cheek type of a wrap-up here, but this will just more so to whet our appetite for questions. And again, we got the graduate level of discussion, so now we're kind of going back to the nuts and bolts and the basics. So just a bit of a vignette. 62-year-old gentleman came to a checkup after a free health screening event at a park. His wife thought he might have a stroke after finding out the results. Known history of hypertension, type 2 diabetes, hyperlipidemia, smoking, blood pressure 140/90, A1C 7.8, LDL 160, not on any meds. So next slide. And so according to our primary prevention guidelines through the AHA, what's the most appropriate initial step in managing the hypertension? And again, since we're a little pressed for time and we want some questions, we could just go on to the next one. So you see there, the AHA guidelines recommend lowering that blood pressure below 130/80 in those with hypertension to reduce the risk. Again, this is, we don't go based off of the office, as Dr. Shaw alluded to. We kind of make sure that truly is an accurate reading and checking at home. But since this would be a first-line agent for this patient, an ACE inhibitor would be appropriate. Nothing wrong with lifestyle changes and other things as well. Let's go on to the next slide there. What lifestyle modifications should be prioritized? And again, a little tongue-in-cheek here. I know we're towards the end of the day, so all of us in the clinical world understand that we hear it all, and we have patients that think they're trying to do the right thing. As we know, the social media and kind of the lay public are inundated with other things that they feel are most appropriate. And so we can go to the next slide. We know that this is the moderate intensity exercise per week that we have to engage in, and Dr. Shaw was able to break that down in great detail with us. So what's the recommended therapy for managing the hyperlipidemia? And again, we've discussed this, that statin therapy is first line. You should get aggressive based on risk factors, and we could also include the other agents as needed, but that first line is very important. And then finally, the recommended approach for managing the patient's diabetes. There's various things you can do, but the most appropriate thing in this patient is the next slide, which is around, you could go to the next slide. The lifestyle modifications and metformin. Again, this is based off of our guidelines. We've had AHA guidelines for primary prevention of stroke since 1990, but we, again, based off of a lot of the studies, and especially around the Sampras trial, which I talked a little bit afterwards, even though there was symptomatic stenosis and we tended to send patients for intervention, there is a habit of kind of deferring either to a primary care clinician or defer to someone to do an intervention. But once we got that study back, when you looked at it, you figured out that aggressive medical management was really what won the day for that study, and it really had the stroke community reimagine how we can take care of our patients and be more proactive. And I really think since that time and other studies, the guidelines for primary prevention 2017 and most recently last year have really kind of brought on the depth and breadth and the best practices that shouldn't only be looked at by stroke neurologists, but cardiologists, by primary care clinicians, even surgeons who have these patients go through their office.
Thank you so much. You have called upon the questions gods to start sending things in, and we are getting a lot of questions. based upon this one topic, we might have to have a separate whole webinar around it, but are there any research cohorts that are focused on menopausal women? And then there's a question, can you discuss the risk benefit of hormone replacement therapy for women? And how about stroke risk with oral contraceptives?
Well, that's like, I mean, right, that's like a whole, we could have a whole webinar on that probably. I mean, I guess stroke risk with oral contraceptives, I'm happy to take a slight stab at that. I mean, I think estrogen-containing oral contraceptive pills do seem to increase the risk of arterial and venous thrombosis. That's a real effect. However, the absolute risk for the average person is really quite low, right? So, because 10 times almost zero is still almost zero. So, right. So I think in general that risk is very, very low. So in people who've never had an event, right, like this is a primary prevention space, I don't think we worry very much about that. Someone that has a history of arterial venous thrombosis, that's maybe different. But I guess that's like the softball part of the question, I guess.
Well, no, it's a great kind of table setter of sorts. And when you have cases like that where there's estrogen containing hormone replacement therapy, you still have to look at the whole patient. You do have to, that's where counseling comes in. That's where art meets science. That's where, as Dr. Mullen mentioned previously, you really have to know your patient. If your patient's not going to be able to sleep at night knowing that there is a risk for thrombotic disease with the estrogen containing hormone replacement therapies, then you want to let them know that. You also want to ensure that you know the whole person. Is this a smoker? Is this someone that has a family history, as Dr. Shaw was alluded to? If they have that in their background, if they've got a sedentary lifestyle, and if they do have elevated blood pressure and other vascular risk factors, you really don't want to add fuel to that fire. And so that's really where you want to take that time and discuss it. But again, if it's someone that says, look, I am menopausal, this is interrupting my life, I cannot interact at work or at home, I am not myself, then it's just a risk benefit discussion. Now, I know, early onset menopause, endometriosis, premature organ failure, or ovarian failure, I should say, before, kind of in the early stages of middle age, the 40s or so. It may not seem to be at a time when someone's has an elevated risk of stroke, but those do have an increased risk of stroke. And so again, that's why these kind of discussions are very, very important. And you kind of have to start the vascular risk factor discussion in folks that are, perimenopausal or early onset menopause before normal. And again, this is where it gets very tricky when it comes to our female patients, in that when you compare, they tend to have healthier lifestyles than their male counterparts. But once they get to this era, even though they have the healthier lifestyle, their risk for vascular disease does tend to go up, and you need to have that discussion with them.
Perfect. So I'm going to combine a couple of these questions here. So these are concerning primary care providers. So how do you as specialists communicate with primary care providers to assure they know the guidelines and optimally treat the patient? Additionally, there's a question that says, do you think there's a challenge with the use of many people using urgent care centers for primary care or telemedicine? Do you think planning for prevention and surveillance of disease, do you see a problem with that, and have you seen that in your practice?
Yeah, I can start with that one. Yeah, absolutely. I mean, I think some of the problems with the things that we talk about, unless you have a complication with one of those risk factors, all these risk factors are silent things. People don't feel them. And until they're a problem, no one thinks about it. Different from a rash on your face, you're going to go try to see a dermatologist immediately because you can visibly see the problem. And so that's the challenge. And I think that's where, sure, it's important to make sure all providers have the education, but I think more importantly that the patients have the education. patients understand like, hey, blood pressure is a problem in this country. Lipids are a problem in this country. Obesity is a problem. Go seek help. I think the vignette that Dr. Hicks showed is awesome, and then we need to do more of that, like community health screening, community health fairs, where people can get a free assessment of their risk, so that they can then go and take that to a primary care provider or even a specialist. And so I think education is a big thing, both on the patient side and the provider side. I think whenever I see a patient, I always try to collaborate with their primary care doctor, so that the care is sort of continuous, and we coordinate care around the patient, so there's no confusion on the patient's part what they necessarily need to remember to relay over. We don't kind of try to put ourselves in silos where I'm only going to deal with this and I'm only going to deal with that. We try to work together to make it easier for the patient, and I think primary care providers, at least that I've interacted with, really like that. I think there's a lot of opportunity in this day and age of social media, AI, and other things to really also help at a large scale through a health system screen people who are at highest risk and try to get them in an automated way to go seek help to primary care providers or specialists. So a lot of opportunities. We need to do better for sure, but it's so crucial to have closed loop communication between all providers on a patient's care team.
Yeah. I would mention around kind of modern collaboration with primary care and specialists. EMRs have taken over everyone's life, and that could be a blessing and a curse. I think that what it can do on its best day is ensure that if you're dealing with a certain condition or a disease state, say asymptomatic carotid stenosis, and that example of a primary care doc saying you got to see the stroke team or else you will end up on their stroke unit, you're about to course correct what maybe was discussed with the patient, you've got to show your work. You've got to document the why behind it. I've heard from primary care docs who really appreciate the why behind what you're planning on doing, and potentially with the data behind it. All of us are busy, specialists and primary care as well, but in the way we can have dot phrases that can quickly bring up important actionable recommendations and the reason behind them in your assessment, along with ambient listening devices to make the note a little bit easier to compile. Doing that can ensure, and kind of letting the primary care know kind of what you're thinking and why, really goes a long way, and it really helps the patient at the end of the day. Because if you just want to write a quick note and say, this was, I don't know why this patient was referred to me, there's no data to suggest it. You've got to explain it in a way to where the patient isn't harmed in the first place. Because what I've seen far too often is the primary care doc saying, well, they weren't helpful, I guess I have to manage this myself, and I'm going to either find another provider, or I'm going to take you straight to the proceduralist, or I'm going to continue to medically manage this the way I feel most comfortable. And if that's guideline driven and kind of evidence-based, based off these primary prevention guidelines, that's phenomenal. But sometimes it isn't. And so it really behooves the specialist to explain the why behind everything we do. And then, of course, if it's something critical, you got to pick up the phone and talk to the provider. I think that's a lost art, unfortunately.
We are at the top of the hour. I just want to read this one comment. It says, not a question, but rather just a big thank you to the whole team who helped bring this together, and the panel. Very informative and great to hear from doctors that truly care about their patient populations. I think that kind of says it all. I want to really thank our amazing panel for sharing your time and expertise. Thank you to everyone for attending. Once you leave today's webinar, you will receive an email with a short survey. We'd appreciate it if you complete that so that we can get your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. So on behalf of the American Heart Association and our presenters, I want to thank you for joining us. I always feel kind of strange saying Happy Stroke Month. It's not a happy thing ever when you have a stroke, but really Stroke Month is our opportunity to honor the passion and commitment that you all exhibit in the quest to provide optimal care to your patients in the prevention and management of stroke. So thank you to our panel, and thank you to everyone for the work that you do in your communities and in the front line. So thank you. Have a wonderful rest of your day. Thank you all.
Thank you, everyone.